The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone, and welcome to our webinar on monitoring, evaluation and learning. This is the third webinar in the Health Partnership Scheme Presentation Series, which showcases the range of projects delivered by health partnerships. During our last webinar in March, we heard about the fantastic work carried out by 4 partnerships in Uganda. The recording of this previous webinar is now available on PHET's YouTube channel and website in case you've missed it. I am Sophie Pinder, Evaluation and Learning Officer at PHET. I'm here to facilitate the Monitoring, Evaluation and Learning webinar today and ensure that everything runs smoothly. You should all be able to see my screen, which features the first slide of the webinar session with the PHET logo. You are all currently on mute, so we are not able to hear you. In case you experience any issues with internet connectivity, the slides and the recording will be available on our YouTube channel shortly after the session. If you have any trouble with the audio, you can use the comment box section to let us know, and we will try to address the problem if we can. So you will shortly be hearing about some experiences of monitoring, evaluation and learning, MEL for short, from 3 health partnerships. These presentations will focus as much as possible on the implementation of M&E activities, such as developing data collection tools, analysing data for results. And we thought that this would be most useful since those of you in health partnerships who have projects currently funded under the scheme will be at that stage where you are kind of moving forward with the implementation of your M&E activities according to the project plans and M&E work plans that you have developed. So I'd like to stress that the presenters are really kind of sharing their experiences, and it's not recommendations, because obviously different projects have different approaches to M&E, but we do hope that this will give you an opportunity to reflect on your own projects and help you along the way. You will have the opportunity to ask questions to the presenters after the 3 presentations have been delivered. So now I'd like to introduce you to Dame Tina Lavender, Professor of Midwifery and Director of the Centre for Global Women's Health at the University of Manchester. Tina is the UK lead of the Uganda Africa Midwives Research Network project, which is led by a multi-country partnership between the University of Manchester and midwifery and nursing schools in Kenya, Malawi, Zambia, Uganda, Zimbabwe and Tanzania. The project's objective is to develop a thriving, collaborative and sustainable midwifery research network with the capacity and skills to strengthen evidence-based practice and ultimately to improve care for women and babies. I will now hand you over to Tina.
Hi. Good afternoon, everybody. Hello, can you hear me?
Yes, you can start, sorry.
Okay. Good afternoon, everybody. As Sophie has said, I'm going to talk to you about the monitoring and evaluation for the Uganda Africa Midwives Research Network. I thought that I would start by just giving you a little bit of context of the project, just so that the M&E actually makes sense. So our goal is improved and increased midwifery research generated in the region and more evidence-based midwifery practice. So the goal of our project was not just to do more research, but to do better research. And we had 3 main objectives. The first objective was to identify research priorities, and we did this based on the then Millennium Development Goals, and we used a Delphi approach to do this. And then we used the priorities to conduct research activities, and we did this with alongside training. Therefore, the participants were learning as they were actually doing the activities. and then to develop a collaborative research partnership. The actual countries have already been mentioned by Sophie, but these are our 6 partners. Angela Chimwaza in Malawi, Margaret Mambola in Zambia, Christina Rawdon in Zimbabwe, Rose Laser in Tanzania, Grace Omani, who's the chair of the network, and she's based in Nairobi, Kenya, and Enid, who's in Uganda. And this is an overview of the activities that took place. And we had 6 African midwifery leaders and the University of Manchester team. And then in each country, we supported 20 midwives who attended a series of workshops to learn about the different methodologies, ethics, implementation, analysis, etc., and all the different aspects of the research process. And then we worked more actively with 3 midwives from each country to assist them to become independent researchers. And then the bit that's of most interest today is perhaps the outcomes and how we got to those outcomes. And this is just a picture of our core LAMRA members at one of the learning and sharing events that we had throughout the process. So just to say that M&E was a bit of a challenge, and I think that the problems are that being able to measure something that's easily obtainable, that's acceptable to all the partners and also relevant to key stakeholders. So we had to consider quite deeply what our M&E plan should look like, particularly to address all the different members that would be interested in the plan, but also it had to be doable. And we decided that we would have different approaches to our M&E. And first of all, if we look at the internal evaluation, this was a quantitative evaluation. And these were the things that we have to collect and things that are perhaps a little bit easier to collect. So we looked, for example, at the number of participants who attended all the workshops, then the number of the research protocols written, the number of ethical approvals that were applied for, and also the number of ethical approvals that were gained, the number of research projects that were completed, and the number of clinical guidelines produced. And we also looked at the number of research projects that were disseminated, and some were disseminated through oral presentation, poster presentation, and also papers, publications in peer-reviewed journals. And as I said, these are the easy things to collect, they're very easy to quantify. And this is just showing you some of the pictures of the actual dissemination. The top picture is the Lagina African Midwives Research Network Conference in 2015, where we brought together all the participants in order to disseminate their findings. This was really the first platform of dissemination. And also the bottom picture, we had a LAMRA special edition of the African Journal of Midwifery, and we had 13 publications. And you can see all the midwives very proudly displaying the journal here, and some of the editorial board members too. And we also looked at some of the follow-on activities in terms of the number of grant applications. And we had 4 successful grant applications during the course of the actual project. But importantly for many of the members was to capture the esteem factors. And some of the members had conference invitations as a direct result of being a LAMRA member. They also were invited to be on national and international panels, for example, being a member of the WHO guideline group. So these were extremely important indicators of success. We also had the workshop evaluations, and these are important in terms of moving forward because the model that we were using is very much transferable, and in fact we will be transferring it into parts of India. Evaluation of midwives' attitudes to evidence-based practice and clinical effectiveness was also sought, and we did this using a validated pre- and post-training tool. But one of the things that we came to realise was that some of the quantitative data that we were capturing gave us some indication of success, but it didn't really give the whole story, and it was a little bit more complicated than what we might have first thought. And one of the important aspects of the evaluation was the qualitative evaluation. So the focus groups in each country to understand the training experiences, its impact on individuals, and the potential for strengthening the maternity systems. These were certainly things that we couldn't capture with the quantitative data, but they showed the added value of what we were doing and got to the real depth of understanding. Also, the assessment of the lead partners' experiences was important, and not just the African partners, but also the UK partners as well, because I think that it is a two-way process, and our buddying approach actually demonstrated that we all gain from the experience. And we also did individual interviews and had our own personal reflections, which was very important in terms of moving forward. Capturing the real impact was a real challenge, and we realised part of the way through our project that maybe we weren't capturing everything that we could have done. We knew that informally, when we were discussing all the great things that were happening from the project, that they weren't actually capturing in our original M&E plan. So we decided to have a little bit of a rethink and think, what could we do that could actually capture these important elements and outcomes of the project. So we decided that we would introduce case studies. Informally, we were already receiving these case studies verbally, but we wanted to capture them in a more formal way. So we introduced a case study template, which you can see here. A very simple template and could be used in any project. The title of the project country, because obviously we had 6 different countries, the title of the case study, and then we asked the participants to describe the success story in a maximum of 250 words. And then we asked them to give us a killer fact. So what is important about the success, and to give us that in one sentence. So if they had to tell us one thing from this project that was really meaningful to them, what would that be? And then we asked them to reflect on the success, explain what you're particularly proud of and why you're proud of it. And then we also asked for some supporting evidence. We asked them to attach any photographs, web links, news articles, or anything else. Sometimes it would be supporting letters from their organisation, for example. We found that this was a very useful thing to do and a very powerful thing to do, and it's the one thing that has captured most people's attention. And just to give you an example of a couple of these case studies, although we have got many more. One of the examples was from Kenya, and there was a midwife, Rosemary Madiva. She's a senior midwife who works on the labour ward in Pumwani Hospital in Nairobi. And at the very first workshop, she stated that she had a phobia for research. And in fact, on the very first day of the very first workshop, she was caught leaving the workshop and trying to scurry off without anybody noticing. But we did notice, and we brought her back into the workshop. And at the end of the workshops, at the end of the 2-year process, she said, "Lambron was a dream that came true and has empowered me with vast knowledge on research about maternal and child health." And as a direct result of Lambron, she is now leading the planning and developing of standard operating procedures for the hospital, something that she would never have dreamt of doing at the beginning of the process. So some of the standard operating procedures that she's done is the 3rd stage of labour, postpartum hemorrhage and eclampsia, all really important labour management areas. She's placed the SOPs on the labour ward to directly influence evidence-based practice, and all the midwives are now following these. And importantly for her, she was recognised by the medical superintendent as a research mentor, and she's now supporting others in her organisation. A further example is from Malawi. And Melanie Hammy, who I'm sad to say passed away a few weeks ago, but she was one of the participants who was extremely motivated to improve care for women and babies. And she used her newfound research skills to identify problems and solutions at Namaru village in Malawi. This village is 15 kilometres from the nearest health facility, surrounded by 2 rivers and has no proper bridges. But Lamron enabled Melanie to find the evidence, conduct community mapping and problem tree analysis to identify the challenges in relation to maternal and neonatal health. And the challenges were long distance to the facility, poor road networks, undulating topography and lack of transportation and continuous use of traditional birth attendants. And as a direct result from her research, the community bought a bicycle ambulance which could immediately address the challenges of transportation to bring women that need to be transferred from the rural area into the tertiary hospitals. So as well as our own evaluation, we also decided within our project to have an external evaluation. But in addition to that, we had FET doing our evaluations, we had our financial audits, both in the UK and overseas, we had our milestone meetings, and we had our reports, which were verbal and written. And these were all extremely helpful, actually, very conducive to making improvement as opposed to being punitive at all. But we also decided to commission an evaluation external to our organisation or to that of FET. And we appointed Capacity Development International to do this for us. And I'm not sure whether either Vicky or Emma are on the webinar, but here's a picture of them for those of you that don't know them. So why did we decide to do an independent evaluation? Well, we weighed up the advantages and disadvantages. And I suppose that the disadvantages are fairly few. I think the main disadvantage is the cost. Because we had the multi-country partnership, we were able to use some of that budget in order to do the independent evaluation. And I'm sure that you can appreciate with 6 countries that it's quite complex, and we felt that bringing somebody in would be useful. And so the cost benefit was certainly worth it. Although in smaller projects where the resources might be a little bit tighter, I think this is something really to consider. And I suppose the other aspect which we might not want to reveal is sometimes there's a potential to hear things that you don't want to hear. And I think that we all see our own projects with rose-coloured spectacles. We all want to see all the good in it. And sometimes it is really good to hear the things that might not have worked so well in order to move forward. I think the advantages certainly outweigh the disadvantages in terms of legitimacy, in terms of credibility, believability, but also it enabled us to produce a more comprehensive overview of what our project had achieved, and indeed the areas where we could perhaps improve in future projects. And importantly, it added a new perspective. We were so embedded in what we were doing, sometimes you don't see the wider picture. So from our point of view, having the independent evaluation was extremely valuable. The other aspect that was valuable was having the independent steering committee. And you can see some of the members here. Just to point out some of the key people, we had Ninka van der Broek from the Liverpool School of Tropical Medicine. We had Kali Christensen, Professor from the Karolinska Institute. We had Gaynor McLean, who's an independent international consultant, and we had the global advisor for the Royal College of Midwives, and somebody who's not on the screen on the picture is Matthews Mathia from the World Health Organization. And we found the steering committee extremely helpful in actually reviewing our plans, reviewing our evaluations, and actually guiding us in areas that we could actually move forward. The other group of people who were particularly valuable were the local stakeholders. In each country we had a local stakeholder group, and this is the Malawi stakeholder group. And we had members from academia, from clinical practice, from the ministry, from NGOs, charitable organisations. And these groups were also helpful in specifically to look at the local context as well, and in terms of implementing anything that was revealed within the project. So, for example, in terms of the research outcomes, any further training that might be required, any integration into local curriculum, etc., etc. So this was a very, very useful group in each of the countries. So in terms of the lessons learned, we learned an awful lot within this project. I think firstly, I couldn't emphasise enough that you really need to use mixed methods, that using the quantitative approach alone does not give you all the answers, and it certainly doesn't give you the whole picture and the power of what these projects can actually achieve. I think involve all partners in the M&E right from the beginning, all the stakeholders and the steering group. I think there's a need for regular and clear communication to the members about what is being done and why it is being done. We found it particularly helpful to allocate one individual who had overall responsibility for M&E, but then we also had local M&E champions in each of the 6 countries. I think another point is that you shouldn't really worry about changing the M&E plan if it's not capturing what you want it to do. And we found that particularly valuable, introducing the case studies. They added so much to our overall evaluation. I think also allowing time in the training programs to address M&E issues, because sometimes it's something that's seen as a little bit away from the overall activities of the project. And I think by having a session within the workshops actually helps you to consolidate what you're doing and also to make sure that everybody is on the same page. And I think also sometimes don't think too big. I think that, at the start of this project, we were thinking a lot bigger than what we actually honed in on. But I think whatever you do, you have to just do it very well, as robust as you can. And thank you very much for listening.
Thank you very much, Tina, for your presentation and for sharing your experiences with us today. It's been particularly interesting to hear about the lessons learned and how valuable it is to use kind of mixed methods, that quantitative data can show some results and indicators of success, but not all of them, and also the value of commissioning an independent evaluation, the pros and cons of it, and also the benefits that this can have in order to give you a new perspective on what's been done and any kind of expected and unexpected impact that has come from your work. So now I'd like to introduce you to Dr. Dylan Bolt, who is an anesthesiologist and co-director of the Zambia Anaesthesia Development Program, ZADAP for short. And this program is led by a partnership between the Association of Anaesthetists of Great Britain and Ireland and the University Teaching Hospital in Lusaka, Zambia. and the goal of the overall programme is to create sustainable capacity for safe anaesthesia care by developing the skills of local anaesthesia staff and trainees in patient safety, education and leadership. I'm just going to pass you on to Dylan right now. Hi Dylan, over to you. Dylan, I think you're still on mute on your computer.
Can you hear me now?
Yes, we can hear you.
Fantastic. And can you, thank you. And can you see my screen? Hello. Okay. So I'm going to assume that everyone can see my screen as well there. Thank you very much for the introduction, and thank you to Tina for that really interesting talk. I think that the program we've just heard about was quite far ahead of us in terms of monitoring and evaluation, but I'm quite happy to talk about some of the challenges that we've had with our program. As a bit of a context, our program looking at patient safety initiatives in anesthesia in Zambia was in the context of a larger program, which was the establishment of a postgraduate anesthesia training program at the University of Zambia that started just a year before our program. And our ZADP program was very much working together with that University of Zambia Master of Medicine anesthesia program and intending to support it. What we wanted to add, that anesthesia training program...
Sorry to interrupt, we can't see your screen. Yeah. Just checked with someone.
Oh, you can't?
No.
Okay.
So what I'm going to do is change back the presenter function back to me and then switch back to you, and hopefully it'll work. Really sorry about that.
No, that's okay.
Okay. Right, so everyone should see my screen now, and I'm going to switch back to you. And do you have the show my screen function now? Yeah, great.
I do. Can you see the screen now?
Yes.
Fantastic.
Sorry.
Okay. And so what we wanted to do was, in order to add to this educational program, which was taking medical students who'd finished their training at medical school and training them to be physician anaesthetists, was to focus more on systems and processes of care and patient safety. And in the first year of that educational program, we'd realized that one thing that had been missing was a focus on systems of care, and that we could spend so much time educating individuals about anesthesia skills, but until we looked at some of the systemic issues, there were still going to be grave deficiencies in perioperative care and outcomes. So, as you've mentioned, it was a partnership between the Association of Anaesthetists of Great Britain and Ireland and the University Teaching Hospital Department of Anaesthesia in Lusaka in Zambia. And the other thing that was really key about this program is it was a collaboration by trainees. So the person who developed the program was an anaesthesia trainee in the UK, the person who wrote the original grant and led out our activity plan and our monitoring and evaluation. All of the volunteers who went over to visit Zambia were senior UK anesthesia trainees, and our focus was on working together with local anesthesia trainees in Lusaka. So that was quite different from the broader Master of Medicine program, which was mostly consultant anaesthetists from Canada and from the UK going over to teach. So our overarching goal was to improve patient safety in perioperative care at the University Teaching Hospital in Lusaka. And when we tried to think about how we could monitor this goal, we came up in the original monitoring and evaluation plan with two main indicators. The first was to look at serious untoward incidents in anesthesia. So perhaps a patient case where something went wrong, or where there was negative harm to patients, or even near misses when it was clear that something had gone wrong in the anesthetic or the intensive care, and although it hadn't actually negatively harmed the patient, it easily could have done. And these kind of incidents should be reported and discussed internally within the department and perhaps externally as well, and monitored. And this is certainly standard practice in the UK, but wasn't practice at all in Lusaka in Anaesthesia when we started the program. And I think the original thinking here was that these events were relatively common. They were things that while we were going over to teach, we were seeing really all the time, many times a week, and hearing a lot about these. And that if we managed to affect patient safety in a positive way, then there would be less of these events. And so when we started thinking about it, it seemed to make sense that if we measured the number of serious untoward events in anesthesia and the number was going down over time, then this would be a good indicator of our goal of improving patient safety. I think that most of the thinking behind this, unfortunately, was quite flawed, and we learned a lot from this. And I think that it's an illustration to us of how it's very easy to pick something that doesn't really measure what you want it to measure at the beginning of a project. I completely agree with what Tina said about don't feel that you have to stick with the original indicators if you feel you should change it if it's not measuring what you think you should. I kind of wish we'd done that a little bit earlier. The main problem with the measurement of serious untoward incidents was that they actually were never being reported at all at the beginning of the project. We had really no baseline data about how many serious untoward incidents there were. And because we didn't really have a reporting culture and a no-blame culture, it just wasn't happening. And so, in actual fact, over time, we had an increase in reporting of serious untoward incidents because some of the things that we were trying to do was improve reporting culture, and so people started to report incidents that they wouldn't have reported previously. Still, I think these were underreported. What we ended up doing as our indicator was actually turning on its head and deciding that if we could have an increase in the number of incidents reported over time, over the 24-month span of the project, that this was actually a positive thing and showed that we were actually at least affecting the reporting culture, although unable to actually really give a good measurement about how many of these events were happening over time. The other indicator for our goal was to look at perioperative mortality rate at the University Teaching Hospital, and we wanted to look at the mortality rate in the first 6 months and compare it to the mortality rate in the last 6 months, planning to look at very simple things like the theatre registers, and then go to the mortuary and then match up the patients in each list and see how many patients had died within 7 days post-operatively, thinking that if we managed to make a real effect on patient safety, that we'd actually see less patients dying over that period of time. I think, again, this was really not a very good indicator at all for our goal, and really we never really managed to achieve what we wanted to achieve. And there were a couple of reasons for this. I think the first is that really the goal was really too lofty. I think that we were very ambitious and enthusiastic, but realistically, trying to show a patient-level outcome in mortality over just 2 years in a very complex institution with very, very many complex problems was just unrealistic, and we were never really going to be able to show this. In addition to this, we hugely underestimated how hard it was going to be to actually collect this data. And when we started to go through the files and the books, we realized there was a huge amount of data missing, many things recorded inaccurately, and it was very, very hard to actually get this data. We persevered because we thought it was really important to understand what the perioperative mortality rate was, and we kind of changed this goal, this kind of indicator for our goal, that by the end of the project we just wanted to have a good estimation of what perioperative mortality rate was so that we could then aim to improve it in future projects, in future parts of this program. And we actually managed to get data, but it took us about 2 years to actually get the data. We ended up publishing it in a peer-reviewed journal. And even so, we were missing probably about a third of the data that we wanted, so we could only really make very broad estimates of what perioperative mortality was. I think some of the really positive things about this, though, was that it enabled us to go through cases in quite some detail. And so we went through patient case notes, and we discussed what had happened before mortality with the surgical teams, and we got independent surgeons and obstetricians and an anesthesiologist to review each case for which we could get data. And this enabled us to get some really quite detailed and interesting data about why patients had died and about avoidable causes of mortality. And the advantage of this is that it really helped us understand what was going wrong with perioperative care at UTH and helped us plan future projects. And I think our current project, which focuses on the management of major hemorrhage and massive transfusion, really came out of this data, and I think is now much better organized from having this data to work on to start off with. So our goal in the red box on the right was improved patient safety, and then our outcomes, which were supposed to lead to this goal, are listed on the left. And we had 4 main outcomes of improved systems and processes, improved teamwork and communication, leadership and crisis resource management, and improved assessment of and management of the critically ill. And these factors we aimed would, when improved, would lead into improved patient safety. I'm just going to pick on a couple of these and how we plan to monitor and evaluate them for examples. The first was improved systems and processes, and really we focused just very much on the World Health Organization patient safety checklist. And the indicator that we chose is to try to look at the how often the checklist was used, and then whether it managed to pick up whether latent antibiotics were administered and available for patients when indicated. And we used this because there was a recent study before our project started that showed that the use of the WHO safety, surgical safety checklist was associated with improved mortality in exactly the kind of low resource setting that we were working with in Zambia. I think this we managed to actually monitor fairly well in terms of repeated audits. First of all, we had an audit where people were self-reporting, and this really wasn't very successful at all because there was a bit of a reporting effect where people reported a little bit better than was actually going on. And then we followed up with some kind of secret audits where people monitored without telling people that they were being monitored, and we realized that actually the compliance was a lot lower than we expected. And in fact, one problem with this is that although people were using the checklist, often there simply wasn't blood available even though it was identified that it was a need, or antibiotics weren't available even though it was identified that it was a need. So I think the problem here for us was that even though we managed to measure the things that we wanted to measure, this was intended to achieve our goal of improved patient safety, and that just wasn't happening because the resources weren't available, even though they were using the checklist in Lusaka a lot of the time. And so I think what we really didn't consider at the start of the project was the assumption from outcome to goal, and what happened if that outcome to goal assumption wasn't met. And that was something I think that we wished that we had thought about a little bit earlier on in the project. Another key outcome that to lead to our goals was improved leadership and crisis resource management. And here we were hoping to demonstrate self-awareness and team organization amongst our new leaders in anesthesia in the training program. To do this, we used structured interviews of healthcare professionals around the hospital, both in anesthesia and outside anesthesia, and it aimed to look at the debriefing of teams in mortality and morbidity meeting. And I'd like to echo what Tina was saying earlier on, that we really found this qualitative data much more useful than some of the quantitative data, which really we didn't have systems in place to collect the kind of data we needed to show what we wanted to show. But the qualitative data was very useful. I think one of the key things that we learned from this, that certainly there was improved leadership skills from formal leadership training and crisis resource management training. We wish that we had put a little bit more focus on resources to do these interviews in our initial grant, and especially in terms of resources to do analysis of the qualitative data. I think we underestimated quite how much work it was to collect and analyze this data. We didn't really manage to get baseline data in time, but we got good follow-up data, but somewhat difficult to compare without the baseline data. And then moving on the left, so we have our outcomes and our goal on the right that we've already discussed. On the left, we had a number of outputs that we aim to achieve in order to achieve our goals. This included outreach visits to major provincial hospitals, and then lots of short training courses for both physician anaesthetists, non-physician anaesthetists, surgical trainees and obstetric trainees, and also some much more difficult to define goals in terms of culture change and clinical governance process change, developing mortality and morbidity meetings, and a kind of reporting culture. I think one of the problems here for us was that there were really too many outputs that we were aiming to achieve. And some of these outputs were really quite loosely connected to our outcomes. The way that it all tied together was not necessarily as logical as it could have been. I think the problems with this is that it gave us an awfully large number of indicators that our team were trying to collect information on. And actually people got a little bit dispirited because it was hard to really see how some of the indicators were really going to lead into our ultimate goal. And some of the indicators were obviously quite unachievable, so it became frustrating every 6 months trying to do the monitoring and evaluation when it became obvious that some of the things we'd put on the original M&E plan were never ever going to be achieved within 2 years. And I think again some of the goals were probably a little bit lofty, especially trying to achieve significant culture change in an institution within 2 years is a lot to aim for. We also had rather too much a focus on anaesthetists and anaesthetist training. Most of the courses focused on this rather than our surgical and obstetric trainees, and we realized that it's hard to really achieve change in terms of systems when you're really mostly focusing on one specialty and one professional group. We also, in addition to all this, had 4 specific patient safety initiatives, trying to get a checklist for equipment and improve equipment organization and storage, improving post-anesthesia recovery care, trying to improve the availability of drugs and equipment, and some airway management protocols. These actually went much better. I think these were much more concrete things that our trainees were able to wrap their head around and worked really, really well. I think these were some of the things that we did best and really had a very significant impact on patient care. Equipment that was really not available due to poor organization, donations that were in cardboard boxes never opened or in rooms behind locked doors became available, and really able to improve the quality of care. And I think we were able to monitor these both quantitatively and qualitatively. And I think the lesson learned from us is that really we should have narrowed the scope of our project much earlier on to some things that we really could have measured much more effectively. So in summary, I think the key issues for us were that we tried to do really too much, I think, too soon. Very early on in a project and a relationship with different perioperative specialties and professions in the University of Zambia, before we really had time, a lot of time in the country to build relationships and get to know the system there. And some of our goals were really too lofty. We hadn't really planned or budgeted for data collection or analysis for monitoring and evaluation in our original grant, and it meant that a lot of it was done in a bit of an ad hoc and rushed way. I think the main thing that we've learned is that monitoring and evaluation is really important, and that you really have to budget quite a lot of resources for this in the initial project plan. We certainly overestimated the local infrastructure in terms of information collection, and a lot of the things that we thought would be readily available weren't. That meant that we really had to reconsider some of our indicators and targets. There were actually a lot of unexpected positive effects, which were sometimes quite difficult to measure, and I think that we felt like the monitoring and evaluation plan that we had was unfortunately not really measuring a lot of the really, really good work we were doing in terms of mentoring local trainees, building them up into being leaders, giving them a real appreciation of patient safety and how systems of care really affect patients much more than any individual aspect of care. We got this at the end with some of the qualitative interviews, but we felt like our original plan wasn't really able to capture some of the good that we were doing. Also missing from our original plan were some key issues about sustainability and how the things that we were doing in the project were going to last at the end of our project. And this wasn't really built into the original monitoring and evaluating plan, but we realized how important this was during the course of the program, and have now written that in much more clearly to our monitoring and evaluation for the program going forwards. Also, there was I think in retrospect nowhere near enough local input in designing the monitoring and evaluation at the initial stage before we managed to start the project off. And I think this was partly why some of the goals and indicators were not as realistic as we wanted them to be. So I don't want to be sound like it was it's very depressing, because I think that we did learn a huge amount about monitoring and evaluation and the value of it, and I think that our program did have a really positive effect, but we certainly found monitoring and evaluation more challenging than anything else, and realized that we had a lot to learn from it. Thank you very much. That's about all I have to say on that.
Hello, hi everyone. Thanks, Dylan, for your presentation. It's a very kind of honest and insightful account of the challenges that you've had to go through, the journey that you've had to go through to monitor and evaluate your projects. There's many lessons to be learned from your experience, and I hope that everyone enjoyed listening. Now, onto our final presentation, delivered by Dr. Alison Hall, Child and Adolescent Psychiatrist and the UK lead for the Child and Adolescent Mental Health Training Project for mental health professionals in Uganda, which is led by a partnership between East London NHS Foundation Trust and Butabika Hospital in Kampala. The project aims to increase access to child-centred psychological treatments by introducing a 2-year sustainable and multidisciplinary training program in child and adolescent mental health, CAM for short, in urban and rural Uganda. I'm just going to pass you over to Alison for her presentation.
Hello, can you hear me?
Yes, we can.
Good, good. Oh, well, and everybody can see my screen, is that right?
We can see it, thank you.
Great. Well, it's been lovely to hear the other two presentations, and I must say I echo Dylan's comment about the M&E being initially, particularly, the major challenge in our project too, mainly because we were so inexperienced, and although I've done research in the past, actually M&E in this context is quite a different thing, particularly when, as you say, you don't really know what you're going to be finding as you explore. And in our project, actually, we were exploring our M&E in different parts of Uganda, not just in the hospital that we were familiar with. My PowerPoint, I'm afraid I wish I'd put some pictures in, because it was so lovely to see pictures in yours and bring it to life, and mine looks a bit dry and a bit detailed, but I thought actually some of the detail might be useful to people to read afterwards. Now to go to the next one, I'm just pressing down, but it's not going. How do I do that? How do I move down to the next slide?
You're able to just, with your keyboard, press on the...
That's what I tried to do.
If you click on the screen first and then try and...
Yeah, maybe that. Yeah, fine. Well, Sophie's already introduced the link, but perhaps I'd say a little bit about where the child mental health work came from in relation to that. So although the link was established in 2004 and really focused on both training and development of services, child mental health was really in its inception. In Uganda at the time, there was one child psychiatrist who was trained in the UK who was close to retirement, and at Butabika Hospital, which is, for those of you who know Uganda, is a parallel hospital to Malago, being a national referral hospital directly under the Ministry of Health. That has about 900 patients. At the time I first went in 2006, the children were all in adult wards scattered. Nobody knew even how many children there were. So I suppose our first bit of monitoring, and to give a baseline, was to actually find the children and assess them before we moved on to develop a specialist children's ward in the hospital. So there was a lot of groundwork before we got that funding for the first project in 2012. So the first project, as I think Sophie has underlined, the main aim, which was to develop a sustainable multidisciplinary training program for mental health practitioners in Uganda. As those of you who are familiar with child mental health in England, our approach is very much a multidisciplinary one, and the challenge in the first place in Uganda was that the professions in child mental health were nurses, very few psychiatrists, and a grade called psychiatric clinical officers who could prescribe, who were mostly from a nursing background and who were the background of services in Uganda. And we'd already provided some training, particularly to that group, but in others. So this project developed from initial training that was carried out before the project started. We wanted to measure the changes in practice, and actually, like Dylan, ended up with rather naive indicators. For example, the ward that we developed at the main hospital was full of abandoned children, so we thought the goal would be to reduce the number of children admitted to the hospital and being abandoned there. The other goal was to increase, or main goal was really to increase the number of children seen by our trained professionals, and to develop specialist children's clinics, because apart from at the main site, children were mostly being seen mixed with adults in adult outpatient clinics. And the final goal was to increase appropriate and referrals that were local throughout the regions in Uganda. By appropriate, in Uganda, like in some other countries, epilepsy is managed in mental health, and by far the largest number of patients referred to services were children with epilepsy, about 90%. And what we wanted to do was to increase the number of children with other conditions that were reaching the services. So we developed a modular training program with the two psychiatrists we trained in the UK. We actually did a lot of work developing a curriculum while they were here, and it was a 12 modules, each lasting 2 weeks, with the idea that you wouldn't be taking people away from their workstations for long, and that there would be clinical practice in their workstations in between. And we had 23 people involved from the UK going out to teach the modules of different disciplines. And the two UK-trained Ugandan child psychiatrists, Dr. Rukundu and Dr. Naluja, were and still are the program directors for the training program. Our goal was to train 20 people in a general assessment and management of children, and we actually exceeded that in 2013. We actually selected more people, particularly from the main hospital, because the cost was relatively less. Then we selected from those the ones with the highest scorers, but also to represent the sites strategically and different disciplines, to do a higher training in psychological treatments, and also to become trainers so that they would be able to train people in future. Again, we planned to have 12. We actually selected 15, and we had 2 dropouts, but ended up with 13. So those were our most important M&E indicators. We also established a first national conference for child mental health, and from the one person we had in 2006, we actually attracted 135 professionals from throughout Uganda, including 15 pediatricians, and that was a wonderful showcase for the training program and also projects which had been completed by our trainees. We did find that we increased the number of children seen by professionals who've been trained in child mental health. However, we also increased the numbers of children seen in total, so still there were a very much larger proportion of children who were still being seen around the country by professionals who were not trained in child mental health. We only temporarily reduced the number of inpatients in the main hospital because the long-stay patients were discharged, but because of a much better service we had far more people coming for admission, and now the ward is fuller than it's ever been, with a much more rapid turnover of acute patients, which I suppose is a good thing, but it wasn't, certainly again it was a goal that we were complete misconception. We were looking at the way things are in the UK, where most of CAM services are in outpatients and very few young people are admitted. We did find that children were being seen closer to their homes, in that there were more children being seen around the regions involved, but still we found that children were coming from far away, even where we had experts now in their locality to come to, particularly to Kampala, to the main two hospitals there, Malago and Butabika. We did see increased numbers of children for conditions other than epilepsy. And then I'll just say about the follow-on project for sustainability, which we've now reached 1 year mark on, so that because I'm going to talk about how our M&E for the first project led into the M&E for the second project. So this project was to support the transition of the training program to the University of Mbarara, and it was also, the plan was, it was aimed for professionals working in public mental health and in child health, rather than for people working in the private sector, which in the time I've known Uganda has developed considerably, and where a lot of staff in mental health get lost, both to the private sector and also to work for NGOs who can pay them better. So part of, I think, the training that our link and other links have been providing in mental health, that we do offer something to professionals in Uganda that perhaps other sectors don't, and we hope that that keeps people together, and so there's less loss of trained staff. The aims of the new project was to make a sustainable course. So we replicated the course over 2 years and had just gone through an enormous amount of work getting it accredited from Mbarara University, and it's just about there. And the aim was to increase the cadre trained clinicians in the regions that are currently not served, and to include child health professionals. Both of those were rather difficult, actually. I'll just comment on that now. Because a lot of the clinicians we trained were working in isolation, there was only one in a region. Actually, the people, they managed to recruit people from their own regional hospitals to train. So actually what we've now improved is the trained group in different regions, which I think is actually perhaps better, and that's again another point about how you plan. We have one trainee working in the Karamoja region, which is very isolated, and he's working not in a regional hospital but in a district hospital. So and it's been very interesting to see how we can support him in training. We also were disappointed not to be able to engage other than one child health professional. The pediatricians really couldn't spare the time to commit themselves to this training program, and that has to be re-looked at, I think, with the Ministry of Health. So the other part of the project was we're supporting the Ugandan trainers to deliver the program rather than having lots of people coming over from the UK. We've had a long-standing strategy for child mental health with the Ministry since 2008, and we're working with them about how we can develop dedicated posts in regional hospitals around the country, and also to keep promoting the specialty at the annual national conference. So to go back to the initial project, the monitoring and evaluation really was in two areas. One was the monitoring of the training program, the quality and the trainees, and the second was the impact on clinical services. We involved stakeholders in the development of monitoring evaluation, particularly the program directors, Dr. Rakundu and Dr. Naluja, and the Ministry of Health in relation to discussions about specialisation and recruitment. They were particularly keen on the specialisation of nurses, and one of the things that has been a slight challenge with the university is having nurses who don't have degrees on the training course, whereas it is really a postgraduate course. But I think it's been actually very successful in having the two groups together. In the training program, obviously we've been involving the university particularly, and the School for Psychiatric Clinical Officers, which is where the program is based. We've also involved potential trainees in the discussion of the program because we knew people from our training around the country. We did a needs assessment, for example, with people we were training before we put in our bid for the project. And then in relation to the impact on clinical services, we've been involving the trainees at the 4 main sites for the project, and also all trainees on the course had to complete logbooks. So to go back now to the training program, we had an important part of the training program was the selection and retention of trainees, the quality of the teaching program that was delivered, and the assessment of the trainees. In the clinical services, we have 4 main sites, Malago, Boutebika, then the university hospitals in Gulu and in Mbarara, and where there were psychiatrists at all those sites. And we gathered additional information from the trainees' logbooks. Then we also assessed the quality of clinical work being undertaken prior to the end of each year at the 4 main sites using a case note sample, and I'll go on and describe those in a bit more detail. First of all, the training program, it was not too difficult to, we were involved in the discussions of the selection of trainees, setting the criteria for the application form, and this was circulated nationally to mental health professionals. Because mental health professionals primarily are trained through Boutebika, they really know each other. There's a nursing school there, there's a psychiatric clinical officers school where we based the course, and the psychiatrists who train at Makerere University also come through Boutebika. So the networks were good. At the beginning of the project, though, many people weren't on email, and one of the, I think Dylan mentioned the unmeasured successes was getting all of the professionals to become IT literate, both in terms of communicating with email and having access to computers, and also developing a sense of group cohesion. Practically every week one gets emails from the trainees to each other, which is really nice. And I think this sustains morale and affects the problems of isolation when people are working on their own. The trainees were selected, as I've mentioned, for geographical and multidisciplinary representation, and in the second year we used the marks that they achieved. So we took the higher scorers as well. We recorded the dropouts and the reasons for the dropouts throughout. So in terms of the delivery of the teaching program, I've marked on the slides in purple the forms that are, or tools that are available for people to access if they're interested. the basic aspect of this form and others was that it was a one-pager, and we kept the same one. So this was much easier to administer, and we'd used it before from previous teaching. So again, one tip I think is if you've used tools in previous work, adapt them, because actually you know what questions are really helpful. And these forms were collected by the UK volunteers at the end of each module. We also had focus groups for all aspects of the course at the end of each year, and this included all aspects, including the clinical training, the food and accommodation, the administration of the course, the application of the course to their clinical work, and also to their development of their local services. One innovation was, which came from, I think, the trainees themselves. They elected a trainee representative early on, and that's been a tradition that's continued, and that person particularly submitted feedback from the peers during the course and raised issues of concern that happened. So they either did it in person at the time of the modules or by email. The big part of this, I'm sorry for this busy slide, but the main thing is, because this was going to be a university course, that was always as it was planned, we actually had a very complicated way of assessing the trainees, which had to meet the university requirements. So, for example, what we call continuous assessment, they call progressive assessment, and that has to account for 30% of the marks of the course. And then the final summative assessment is the examination, the formal examinations, which is 70%. So we worked out the assessment structure, and then adapted the curriculum together, myself and the program directors, with the aim of conforming it to university requirements. And we had a problem because we had two universities involved at the beginning. We had Makerere and Mbarara, and their requirements were slightly different, but in the end we're now linked in with Mbarara University, so the very detailed curriculum that we've now developed was for their requirements. Also, one of the program directors, Godfrey Rukundu, his experience of examining students in the university, he works in the academic department, was invaluable, because he was really good at it and made a wonderful spreadsheet for the collation of marks, which were quite complex, which certainly I wouldn't have been able to do. Tina mentioned looking at things in lots of different ways, and certainly our assessment is very thorough, and it actually is quite good, because apart from on attendance, people can't really fail on any one area because there's not many marks allocated for each area. So there's attendance, then the logbook of clinical activity. In the first year, each trainee had to submit 3 written case studies for different age groups, and in the second year 3 different treatments. For consistency, we double marked them electronically, the UK trainers who'd been involved in teaching plus the program directors and myself. And then we had, each of them had to present a PowerPoint presentation, so they would actually learn to use PowerPoint. And in the first year they did a case study, and in the second year they had to do it on a topic. And this was assessed by the UK trainers who were teaching the course. The UK trainers and the program directors did an assessment of attitude and aptitude on forms for each teaching module and clinical training. Then at the end of each year we had an examination of clinical skills with children in the outpatient department, where those of us UK trainers who were there and the program directors observed each trainee interviewing skills, their presentation of the case and formulation, and note keeping. They had to write notes as well, and that was part of the examination. They also had a written examination, again the topics of which were informed really by what we learned of areas of strength and difficulties during the course. And in the second year of the project, the second year of the course, each trainee had to develop a project which was a topic connected to child mental health, either an audit, a service development project, or research. This was double marked electronically with UK trainers plus the program directors, and each trainee had a separate supervisor from the UK and a separate supervisor from Uganda to help them with the project. And actually, again, I didn't really put that as part of our monitoring and evaluation, but actually they were doing a lot of monitoring and evaluation of their work and finding out interesting aspects of information about their services and problems with the services through these projects that were presented at the annual conference.
Alison?
Yes?
Hi.
Am I ready?
No, that's fine. Just to allow enough time for questions, if you don't mind finishing in the next 5 minutes, then that would be great.
Yes, that's fine. Yeah. Sorry, that's too much detail, I think. Looking at the impact on clinical services, we had to look at the number of dedicated clinics for children and the number of CAMS trained staff on each site, which we got from the trainees, and then the activity data. Now, this was probably our biggest challenge. We gathered it at the 4 main sites by going out on site visits at the end of each year, and we had to manually count them from case notes. In fact, the adult and child cases were all mixed up initially, and it was very, very difficult. But it got much better, and I'll go on to that in the next project. We looked at the number of admissions to, length of stay, deaths, outpatient attendances, and this accounting included the patients that were seen by just by our trainees. We also got additional information about the cases seen from the logbooks. We then also looked at the quality of clinical work, which was assessed, of course, during the course, but on these site visits we took a sample of 20 case notes from each site and looked at most sites except Bouteflika had few inpatients, so we took all the inpatients, or up to 10 at Bouteflika, and then the rest of outpatients, and they were the most recent cases, could be new patients or follow-ups. And we designed a case note monitoring form, which again was a simple one-sheet form to take in patient demographics and indicators of the quality of assessment, particularly looking at child and family assessment, child-centered interviews. There was a big problem with the use of medication. In Uganda, they overuse medication. They don't have appropriate medication, so we looked closely at that. And then we looked at, for follow-up cases, the use of treatments that we'd been teaching and whether they reviewed diagnosis, looked at side effects of medication. We didn't make any adaptations to the tools during the first project, although of course we were gathering new bits of information in different ways. But we did have some results which resulted changes in the teaching program and the clinical training and coursework. For example, the trainees found it very difficult to use information from the literature, which was part of their case studies. So we actually introduced topic presentations so they could actually get familiar with gathering information from their reading. We also used research papers so they could critically look at literature. They had real problems formulating their cases, and it was a problem of either too much detail or insufficient. So case notes were either very brief or they wrote lengths of particularly descriptions of symptoms, but without being able to put things together. We found during monitoring evaluation at all sites that patients were being admitted, particularly very disturbed adolescents, and were shockingly being managed by intravenous diazepam, 20 milligrams, and we brought into the course the hospital pharmacist at Bouteflika and work on managing acutely disturbed adolescents, and that's been something that's been a big point in our new program. We also found that because they were seeing so many cases, one of the simple tools to help them was to send them over individual notebooks that they could keep in their pockets to record cases, and also materials that they could use to play assess children with drawings, etc. during assessments. So the monitoring and evaluation informed the design of the second project, and the tools that we used were mainly the same so that we had consistency, but we introduced two new tools to measure their improvement in teaching skills: a self-assessment form, which we'd adapted from education, and the form for the trainers leading each module to feedback on how the experience had been for them. I won't go into, I've put this in for completeness. People can see what our baselines were for the new project. These were the THET measures that we developed jointly with THET, and I have to say it was really, really helpful compared with the first time when I felt I was working alone and in the dark. The second time, THET had obviously really developed their input for us all in monitoring evaluation. I'll just move forward then. The main innovation in the new project, and again it was interesting because I think Dylan talked about doing the same thing locally there, was that we've now got the people who we've trained collecting their own activity data at each clinical site, and we have a local Patrick or Tim monitoring evaluation coordinator for activity data. We actually pay some money for this, and a spreadsheet has been developed for it, and it's working really well. We now we've got the information up into January, February so far, so that's very exciting, really. So conclusions. What worked? We used simple tools, mostly one page, multiple sources. We had consistent use and the same people administering them mostly in order to hold it together. The information was also collected through discussion with trainees and focus groups. We found our first project had a UK volunteer present for 2 6-month period over the 2 years, and that helped enormously. We've got one this year, but we're going to have a period with no UK volunteers, so we'll have to see as adds to the handing over to the Ugandans. Payments worked, but I think mainly, as I've said, the IT communication, electronic communication and frequent communication, and the relationships that are developed between everybody in Uganda involved with the programme has been really important and exciting. Challenges: the time to analyse. We've got lots of information which we haven't analysed yet, but we will do. Remembering to ensure, because we've got so many bits of information, remembering to ensure that it is all collected at the right time. The lack of medical record systems, and in fact our first project, the husband of our UK volunteer set up an electronic system at Bouteflika, but when we went to use it for the second project we found that the data wasn't being entered consistently because of the lack of manpower, so we're back to manual books again. And the burden of responsibility on the individuals who know the projects well, which is mainly myself and Olivia Carmichael, who is our link coordinator. We actually had an independent evaluation, which I put at the end for people to see, which was commissioned by THET to look at the value for money of this project, and there's some findings particularly in relation to M&E I've included, and our contact details. So thank you very much for listening, and sorry it was a bit too much information.
Hello again, Sophie speaking. Thanks Alison for this very detailed and structured presentation. Really enjoyed the fact that you went into detail about all the different tools that you used to collect activity data, and also the learning and challenges that helped inform your current project. Sorry to have to rush you through your presentation. Also, something that I forgot to mention and that Alison did point out during presentation is that there are a number of handouts which are some kind of the tools that were used, the CAM project, that are available in the handout section in your webinar platform panel. And also, if you are interested, I can send you the full presentation and also the eight handout documents which include data collection tools that were used for the CAM project. So we're quickly running out of time, so I want to leave enough time for questions at the end, so I'm just going to really whiz through. Basically, I've put together some kind of overarching principles and things that have come to mind in terms of implementing monitoring evaluation plans. Some of those were actually mentioned by the presenter themselves, so I won't go into them in too much detail. But in terms of keeping it simple and realistic, I know it's easier said than done, but yeah, sometimes it's best to focus on a sample, for instance, of I don't know, health workers trained to collect robust data rather than trying to collect too much information, resulting in kind of patchy data that doesn't give a full picture. And also the last point around commissioning or carrying out evaluations of your project. So having a terms of reference, which means kind of determining the purpose, the scope, what data you need for your evaluation, and the methodology is very important, and also thinking about the resources and the time frame, which is something that Tina mentioned too. Right, so without further ado, I'm going to open the floor to questions. So you have two ways to ask questions. If you have a microphone, you can put your hand up, which means that you click on the little yellow hand icon in the webinar platform. And the other way is to type any questions you have in the question section or the comment box, whatever it's called. Right. Okay, so we have a question from Joy Kemp, so I will just unmute Joy, and Joy, over to you, you can ask your question.
Hi, can you hear me?
Yes.
Great. Just to say thanks for all the presentations, they were really, really interesting. I was particularly interested in what Dylan was saying about the fact that they realised that their indicators weren't going to capture the data that they wanted, and I just wanted to draw a parallel with our global midwifery twinning project, where we used a self-assessment tool, and we assumed that we were doing a professional association partnership project, so we assumed that the professional associations would improve their score in the self-assessment tool from the beginning and the end of the project. And what actually happened was that the score reduced, so it looked like they had got worse rather than better. But actually what had happened is that people understood more what their capacity could be as a professional association and had a much greater understanding of how far they still had to go in development, whereas at the beginning they might have felt that they were pretty much perfect in nearly everything. And so we learned a lot about, number one, self-assessment tools and how useful they are or are not, but also that sometimes turning a tool on its head and saying that a reduction in the score is actually something positive rather than something negative was, you know, could be a measure of success. So that wasn't a question so much as a comment, and that I really could identify with what Dylan was saying.
Great, thank you, Joy. Yeah, does any of the presenters have anything to add to Joy's comment? Dylan, I think you're on mute.
Sorry, no, I mean, I think that it's interesting to hear that other people's experiences are kind of mirror what we've had. I think one thing that we didn't really realize, and we've had a lot of support from THET, especially recently, about how to do MNE. We didn't really realize initially that we could change our indicators. I think we had this idea that we had this responsibility to the people who had funded us to do exactly what we'd said we'd do, and that any kind of deviation from that was a failure. And it was only kind of like about halfway through the project that we actually realized that it just wasn't working. It was frustrating for everybody, and that it was better for everyone, including THET, if we turned it on our head. And I guess it just took us a while to realize it was even like possible and reasonable to do that.
Yeah, well, actually at FET we've learned a lot through the process too. Obviously, the Health Partnership Scheme has been running for a while, and we received an extension a couple of years ago now, and we've actually been able to improve our processes and our understanding. So, for instance, for the current project under the HPS extension, we've developed a number of tools. And we've also, within our reporting templates, added sections that give the opportunity to health partnerships to amend, to kind of reflect on their indicators and amend them along the way, which maybe was not available, or at least not well thought through during some of the older projects. So yeah. Okay.
I think.
Yeah.
Sorry, can I just say about that? One of the things that people have said at times in our work, that people do say what they think you want to hear when they don't know you, or if people are looking hard at practice, for example, they you might not get the same picture if you're one of the senior people in the project, or if you're going at a particular time. And I think it was quite important. I think Dylan mentioned about looking different people at different times to ask some of the questions.
Yeah. Okay. Thank you. I'm just going to read out a comment that was sent by Sophia Bird-Smith. So she's saying that she has found a similar thing in Kenya, where they've used pre and post confidence rating, thinking that the training would show an increase in confidence, but due to culture of not showing any lack of confidence or skill, the pre-ratings were very high, and so the training showed no or little change. So I think, yeah, the having kind of assessments is also, and the M&E process in itself, integrators in projects, is also an opportunity for different stakeholders to kind of reflect and learn through it. So I'm just going to unmute Joanna, who has a question. Hi, Joanna. Hi, Joanna. Sorry about that. Hello.
Hello.
Hi.
Hi. It's really a question and a comment. Thank you very much. They were very, very good and very useful presentation. And I just wanted to say that I completely agreed with the previous comments and speakers of being flexible and dynamic during the process and during the project, and hearing that we can kind of amend and change the indicator. It's really important, because the situation in some of the countries on the ground, in the hospitals in Africa, in different countries, is just changing so quickly that I have it in my project that baseline data that we obtained a year ago, it's not longer valid at this moment. And I think that with both, when the partners work together, we can make something better of it, but not be stagnated and not take it as an initial project or initial proposal that we just have to deliver, because it won't bring enough benefits for everyone.
Thanks, Joanna. So Alison Dylan, do you have anything to add in terms of kind of the importance of partnership work around monitoring evaluation?
I think, this is Tina, I think an important point has been made in terms of engaging with partners for M&E right at the beginning, and know what will work and what will not work within that setting. And I think that sometimes we do M&E up front and at the end, but I think it has to be a continual process where you're constantly reassessing whether the measures are appropriate, whether the data collection tools are valid, etc. And I totally agree, it has to be dynamic.
Great, thanks Tina. We just have one comment from Joy Kemp, who says that she thinks that this discussion also shows the value of mixed methods, and as you say, Tina, so that you're not relying on one tool to show impact. Okay, we have Mary who has a question. I'm just going to unmute you, Mary. Hello, Mary?
You can't
Have a
access.
question? Okay, sorry, I think Mary's having some issues with her internet. Okay, so I think we don't have any more questions. So I'm going to move on now. Oh. Okay, Mary, I unmuted you, so I'm going to unmute you again. Hi, Mary. Mary, can you hear me? Sorry, Mary, it's not working. So if you have a question, just type it in the question box and I'll read it out. And otherwise, you can also send it by email and I can send it later to the presenters. Okay, so moving on now. So the monitoring and evaluation approaches feature strongly as hallmarks in the FET Principles of Partnership, which I'm sure many of you are familiar with. They're more informally known as POPs, and they have clearly shown how these are translated into success for the partnerships and their projects. So they're available on our website to explore. There's 8 principles in total. And we've also started blogging about issues relating to the principles, so you can keep an eye on our FET blog page. Right, so if you would like to access more resources on M&E, I've included a slide, and this slide is also available as a handout in the handout section. It's called MEL Webinar Handout Resources, where you have the hyperlinks. And so basically under the FET Principles of Partnership page, you'll be able to access some case studies, some guidance and tools that have been developed for M&E. So I've listed some of these here. Oops, sorry. And also I thought it would be helpful for those of you who are considering carrying out evaluations, whether these are internal or independent. I've added a few other links to some resources that can be helpful to kind of get you started and think about the methodologies you want to use and what you want to get out of it. The second link, the bond one, is very, very detailed. I think it's a 30 to 50 page document, but you have a contents page at the beginning and you can just go to what you're most interested in. Right, so before we wrap up, I'd like to point out a few upcoming FET events. We have a sharing and learning event this Friday for health partnerships. It's happening at Friends House in London. And there will be a session around M&E in the afternoon, which we're hoping people will attend. And it's an opportunity to discuss any challenges experienced in monitoring evaluation, and hopefully the various groups attending can kind of help each other find solutions. We also have the FET's annual conference happening on the 20th and 21st of October, which this year will focus on impact evaluation and effectiveness. Registration opens next month if you want to attend, so keep an eye on the website. and we would like to offer the opportunity for participants in the conference to present their research around health partnerships at the conference. And so for that we have launched a call for abstracts, which is open until the 31st of May. All the details are available on our website at the link in the slide. So the evaluation and learning team at FET, Dan, Emily and myself remain available to provide any support you need throughout your projects. As was mentioned, I think, from some of our presenters, it's not just a matter of developing project plans, M&E work plans, and then it's set in stone and you have to go with it. There is scope for reflection, learning, and adapting your plans along the way, and at FET we're here to support you through that process. Feel free to send to me, I've got my email address below and also the HPS email address, any questions or ideas you have. I can share the presentation slide with you, and the recording will be available on the FET YouTube channel and website soon. So thank you very much for everyone who took part in this webinar. We hope that you found it interesting. And of course a special thanks to our presenters, Tina, Dylan and Alison today, for their very valuable insights into monitoring, evaluation and learning. Okay, thank you. Bye.